From Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about surgical approaches to shortness of breath. Our guest today is thoracic surgeon Dr. Blair Marshall. She works here at SMH. Dr. Marshall, thank you so much for being with us.
Thank you so much for having me.
There are numerous causes for shortness of breath, correct?
Oh, absolutely.
So what is the process in which a patient experiencing that particular symptom is actually referred to a thoracic surgeon?
So most commonly, it's when patients have shortness of breath and they see their primary care or pulmonologist, and they undergo maximum medical management to treat any underlying causes, such as things they might inhale, asthma, etc. And once they exhaust all of that, or there's still an underlying problem that's not being addressed, that may prompt further testing that may demonstrate some underlying causes. And the two ones that primarily would involve a thoracic surgeon are severe emphysema or something called tracheobronchiomalacia.
So I want to break down those two types of patients who come to see you and their treatments that are available to them. So let's start with the severe emphysema patient who might come to see you. Why would they require surgery over other treatments?
So although it seems counterintuitive, it turns out emphysema in many patients is destruction of the lung. And because the lung gets destroyed, the blood vessels to that portion of lung do not get destroyed. And so if you can sort of take out that portion, either by removing it or by putting a valve to obstruct it, you can actually get the blood flow shunted to the better portions of the lung and improve their breathing.
So what do the surgical treatments look like for someone with emphysema?
So commonly there's one of two things that are frequently performed. One is something called endobronchial valves, and that is basically an endoscopic approach or a non-surgical approach to lung volume reduction, sort of removing that portion of lung. And that's done with an interventional pulmonologist and or thoracic surgeon, where valves are placed in the damaged portion of the lung that block air from going into that portion, but still allow mucus and secretions. Not every patient is a candidate for that because the lobes of the lung can often have collaterals that don't allow that valve technique to work. And in that setting, a thoracic surgeon can either divide the collaterals minimally invasively, or we can just go in and minimally invasively take out typically the top portion of that damaged lung so that the normal lung has a normal expansion and the diaphragms can return to their normal position and work again.
When you say minimally invasive, why is that preferable?
Certainly in the NET trial, where they looked at lung volume reduction surgically, the majority of patients had an open procedure. And we know that anytime you can do thoracic surgery minimally invasively, the patients do much better. There's minimal blood loss, the length of stay is shorter, etc.
What about other patient groups for whom surgery might be best? I know you mentioned, and I want to try to pronounce this properly, tracheobronchiomalacia. What exactly is that?
So I know it's an odd term and not many people hear it much, but tracheobronchiomalacia, or we shorten it to TBM, so is when a normal person breathes, we breathe by negative inspiration. So your chest opens up and we suck air in. But to exhale, we relax and the pressure in the chest increases. In patients with TBM, the airway goes from open like this with the horseshoe cartilage and the flat back to collapsing like this, and actually patients can't exhale. And they can not only not exhale, but they can't get rid of their secretions. And so many patients with TBM are frequent pneumonia patients in and out of the hospital. And unfortunately, to make the diagnosis, it requires a special scan that is not performed commonly, basically. The other subset of patients who have collapse of their airway is something called EDAC, or excessive dynamic airway collapse. And similarly, their airway collapses on exhale. And so in order to make this diagnosis, the patients need a special CAT scan, one that not only scans the patient while they're breathing in and the airway's open, but also while they're exhaling, they repeat the scan and show the severe collapse of the airway. And that's how the diagnosis is made.
Now, because it requires these special scans, that's why TBM is so underdiagnosed, correct?
Correct.
How common is it?
So it had been extremely uncommon, but what we're recognizing is that more likely it's just underdiagnosed. And so for all the patients with COPD that just get diagnosed with COPD, a fraction of them are going to have EDAC or TBM, and not all of them get scanned because it's not something that primary care doctors or even sometimes regular pulmonologists are thinking about. But we've seen a great increase recently.
So if someone feels like maybe they should be scanned for this, what are kind of the conversations they should be having with their physician?
I think to one, make sure that their medical therapy for their underlying problem has been treated completely. And then there are some characteristic signs, especially for TBM, like if you have recurrent pneumonias, that's a clear-cut indication to consider doing that scan. As well, patients who have really no other reason for their shortness of breath. Like one of the patients that I operated on was a Marine who loved to garden and ran his community garden center. And then it came over the few years that he couldn't even walk to the end of his driveway because he was so short of breath. And it was finally a pulmonologist who did an awake bronchoscopy when they were looking inside his airway and they asked him to cough, they could see collapse of the airway, which then led to the scan and ultimately surgery.
So if someone is diagnosed with TBM, what surgical procedures might be used to help treat it?
So we don't want to operate on people who don't need the operation. And so the first thing that we do is put a stent in the airway to keep it open, and then ask the patients to see how their breathing is. And so many people who have a stent after their diagnosis of TBM will say, Dr. Marshall, I could blow out the candles for the first time in the last, decade, or that I could go upstairs when I couldn't go upstairs before. And so nobody wants a stent in their airway necessarily because it's typically a piece of plastic. It irritates the airway, but it helps us assure that if they undergo surgery for TBM, that their breathing will be improved.
Are there certain people who are not good candidates for surgical intervention?
If they have TBM, they may have other comorbidities. And even in high-risk patients, because the operation can be done minimally invasively now, and there's no other way to improve them, because you can't leave these stents in long-term, we tend to offer surgery to people even when they're high risk, because unfortunately, many of these people can't get out of the hospital with these recurrent pneumonias, and it's really the only thing that's preventing them from getting out of the hospital.
After the stent, is there then surgery beyond that if it's successful?
So once the stent is taken out and confirm that the patient's breathing is better, then we go in and minimally invasively repair the tracheobronchial malacia. And so because their airway's collapsing like this, we put a mesh on the back of the airway here to keep these rings of cartilage in position and to prevent this flattening or stretching of that back membrane.
Are there lifestyle changes which need to be made before surgery, which can either prepare the patient for surgery or prevent the need for surgery altogether?
So there are some patients who may be morbidly obese and they're challenged with the exercise. And as you gain weight, you can also gain fat inside your chest. And so if it's the obesity that's causing this flattening of the airway, certainly weight loss may improve their symptoms. And so we recommend that everybody that might be on the morbidly obese scale have a trial of weight loss and at least lose about 20 to 40 pounds before determining that they need an operation.
What about for the emphysema patients? Do you recommend any other treatment options first before you go to surgery?
So all emphysema patients should do pulmonary rehab, and that can improve their stamina, and that's basically exercise and breathing exercises with oxygen. And so, again, maximizing their medical therapy as well.
Is there anything which can be done to prevent emphysema or TBM prior to, if you're worried that you're headed that path?
Yeah. So emphysema, many cases of emphysema are related to smoking. And unfortunately, quitting smoking doesn't prevent the cascade of events once it starts. And so the reason that you get emphysema, which is, again, another big word that people can't relate to, but I like to explain it to patients, that it's the loss of elastic recoil. So that when you blow up a balloon, you let it go, it deflates. And our lungs are very much like that. And so when we breathe in, we let it go, we relax, it deflates. When you get emphysema, those tiny air balloons don't deflate. And so the air starts trapping on the inside and destroying the membrane of the lung. And so the lungs are getting bigger but less functional. And they fill the chest so much and press down on the diaphragm that patients can no longer get the air out as well.
So then, if quitting smoking doesn't prevent emphysema, if you've already done that, what are the lifestyle changes you recommend if people are worried they might be headed down a path or can they prevent TBM?
So there are two different disease categories. And I think TBM, we're not quite sure why we're seeing such an increase in diagnosis. It may be in part morbid obesity, but it may also be reflux. And some people even hypothesize inhaled steroids. That was a new drug on the market in the last 20 years. And so is it the inhaled steroids affecting the proximal or airway early on before it gets to the lungs? And so once you have it, we don't know a way of stopping it other than weight loss and maybe reflux control, if that's a component. For the other end of it, the emphysema, I think being physically active, exercising, stamina, staying healthy are key components to kind of longevity of your lungs.
Is there anything else you'd like to add on this topic?
You know, anyone who has shortness of breath and their quality of life is suffering, it's probably worth taking extra steps to rule out things that could be otherwise fixed.
Dr. Marshall, thank you so much for joining us today. As always, we encourage everyone in the community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.